Welcome back to the Decode Healthcare Masterclass. Man, we are celebrating a massive milestone today. This is part 70 of our comprehensive Inpatient DRG explainer. After our intensive deep dive in part 69, where we unpacked value-based care frameworks, MACRA, MIPS, ACOs, and all that risk adjustment and HCC coding integration, we finally reached a pivotal mid-course checkpoint. Today, we are bringing the whole shebang together. We're stepping out of the textbook, throwing on our clinical detective hats, and tackling some high-stakes, real-world DRG audits.
But before we put your skills to the ultimate test, I just want to remind you to support this milestone. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. It's what allows us to keep bringing this high-level RCM education straight to you for free.
All right, let's take a quick look at our agenda for today. We'll start with our mid-course mastery synthesis, move into a complex medical audit challenge, tackle a surgical denial defense challenge, cover DRG mastery and CDI best practices, and wrap up with our masterclass roadmap and teaser.
Let's jump right into Section 1, Mid-Course Mastery Synthesis.
So, to survive these audits, we have to ground ourselves in the foundational rules. Over the last 69 parts, we've built the pillars of inpatient coding, and the most crucial point to remember is separating the initial symptom that brought the patient in from the ultimate principal diagnosis. It's such an easy trap to fall into. The primary reason for admission might be, severe chest pain. That's the day one chief complaint. But if the tests confirm an acute inferior wall myocardial infarction, well, that is your principal diagnosis. That diagnosis completely drives your DRG and your hospital's reimbursement. Code just the chest pain and you land in the wrong major diagnostic category, and trust me, you'll be facing a severe underpayment.
You'll often spot this trap right away on an inpatient face sheet. The admitting diagnosis there might be something incredibly vague, like fever of undetermined origin. But as clinical detectives, we know better than to just take the face sheet at face value, right? Especially considering how messy doctors' handwriting can be. We have to dig deeper. We have to comb through the discharge summary, the H&P, and the lab reports to confirm the true principal diagnosis, which in a case like this might actually turn out to be acute pyelonephritis.
Now, understanding this cross-continuum payment integration is absolutely vital. Medicare's MSDRG system relies heavily on complications and major complications to adjust your base rate. But if you look at state Medicaid programs, they often pivot to the IPDRG system, which uses a 4-level scale for severity of illness and risk of mortality. We're connecting a lot of dots here. Knowing exactly which sandbox you are playing in completely dictates your audit strategy. This is where things get really compelling. Capturing just one valid major complication or comorbidity, an MCC, can literally thrust your claim into the highest payment tier. It has a massive, direct impact on your case mix index. The MSDRG logic operates on 3 distinct tiers, and missing a valid MCC just because of poor documentation, that means you are leaving legitimate, hard-earned revenue right there on the table.
Moving right along to Section 2, Complex Medical Audit Challenge. All right, it's time to plunge into the field. Imagine this chart lands right on your desk. You've got an elderly patient admitted in severe respiratory and metabolic distress. They are dealing with severe dyspnea, altered mental status, fever, and hypotension. On top of that, labs show an elevated troponin, specifically type 2 demand ischemia, alongside acute renal impairment. That is a ton of clinical noise, and the very first diagnosis we select is going to change everything. We've got a classic diagnostic conflict on our hands. If sepsis is present on admission and meets the sepsis 3 definition of life-threatening organ dysfunction, does it override the severe aspiration pneumonia as our principal diagnosis? Well, the answer lies in our official guidelines and the sepsis 3 clinical validation defense. If sepsis is present on admission and is the fundamental reason for the hospitalization, then that systemic infection must be sequenced first. It beats out the localized aspiration pneumonia. So how do we actually build that bulletproof coding sequence? Step 1. We follow the official logic and establish the systemic infection, so we code the sepsis, like A41.9. Step 2. Since the patient has acute renal impairment and altered mental status linked directly to that infection, we have to add the severe sepsis code. Step 3. We code the localized infection, the aspiration pneumonia. And finally, Step 4. We code out those specific organ dysfunctions.
But wait, while we are resolving this conflict, we absolutely have to eliminate that elevated troponin from the top spot. According to our strict coding rules, a type 2 demand ischemia, which is just caused by the severe metabolic stress of the sepsis, is fundamentally different from an acute NSTEMI. It can never be the principal diagnosis. It's simply a secondary manifestation of the underlying crisis. And here is the financial reality of getting this right. By clinically validating and capturing the altered mental status specifically as acute metabolic encephalopathy and ensuring we code the acute renal failure, we lock in our MCCs. The relative weight for this severe sepsis DRG jumps massively to 1.9015. If we had just vaguely coded altered mental status and a generic pneumonia, we'd have missed the MCC entirely, artificially deflated the hospital's case mix index, and completely underrepresented how sick this patient actually was.
Next up, Section 3, Surgical Denial Defense Challenge.
Let's shift gears from medical ambiguity to a surgical payer denial defense strategy, because surgeries introduce a whole new layer of complex ICD-10 PCS logic. Here is the clinical timeline. Our patient had a laparotomy for an elective open colectomy to treat colon cancer. After the surgery, they suffered severe acute blood loss that required a blood transfusion. Later on in the post-op period, they developed acute tubular necrosis and a prolonged post-op ileus. Predictably, a commercial payer is trying to downgrade this claim, trying to argue that these severe complications are just, quote, inherent to the surgery. We have to prove them wrong. When we formulate our appeal against this downgrade, we have to meticulously differentiate between an inherent post-operative status and a clinically validated secondary MCC. Look, an expected small drop in hemoglobin, that's inherent. But acute post-hemorrhagic anemia requiring a transfusion of blood products, that is a codable complication. We also need to capture the exact ICD-10 PCS root operations, both the open colectomy and the transfusion, because those specific codes are what drive the surgical DRG partition. Now, your absolute best friend in this bulletproof defense is the present on admission, or POA indicator. The payer is definitely going to try to strip that acute tubular necrosis off the claim to lower the DRG weight. However, if that complication is documented with crystal clear clinical indicators, like spiking creatinine levels post-surgery, and perfectly tied back to the procedure, we can absolutely defend it. They cannot just arbitrarily remove it simply because it developed after the admission.
Moving on to Section 4, DRG Mastery and CDI Best Practices. To consistently survive these high-stakes audits, we need systematically precise clinical documentation improvement workflows. Because listen, great coding literally cannot fix poor documentation. High-performing CDI specialists are constantly hunting down ambiguous diagnoses and generating concurrent queries while the patient is still in the bed. You've got to resolve those conflicting notes, like when the attending writes UTI, but the nephrologist clearly writes pyelonephritis. A possible pneumonia documented at discharge might sometimes be coded, but getting a definitive physician query answered is for sure the gold standard for compliance. Mastering these CDI query triggers is exactly how you protect your case mix index. For instance, asking a physician to clarify if heart failure is acute on chronic rather than just writing a generic CHF. That is the exact type of ethical optimization we want. It changes the code from a non-CC to a very powerful CC or MCC. We aren't trying to invent severity here. The goal is simply to make sure the medical record perfectly reflects the severe reality of the patient lying in that hospital bed.
Finally, Section 5, Masterclass Roadmap and Teaser.
You guys have successfully navigated the mid-course assessment, synthesizing 70 parts of deep dive DRG logic into real, actionable audit strategies. But hey, our journey as clinical detectives is far from over. In the remaining parts of this masterclass, we are prepping for advanced revenue cycle management, specialized clinical deep dives, and AI-driven prospective models. And guess what? Starting in our very next explainer, Part 71, we are going global. We're going to compare the US MSDRG system directly with the Australian ARGG and the German GDRG frameworks. You absolutely won't want to miss seeing how the rest of the world handles inpatient grouping.
Thank you so much for joining me for this major milestone today. We've covered some incredible ground. But before you log off, I want you to ask yourself this. How many hidden MCCs is your facility leaving in the charts right now just because of a single missing word? Think about it. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Stay focused, keep analyzing those charts, and I will see you in Part 71.